Heart disease isn't just the number one killer in America, it's the number one killer of women. More women die of heart disease each year than from all cancers combined. And here's what makes it so dangerous. Women are often told that their symptoms are just stress or hormones, so they don't get the right tests or they don't get the help they need until it's too late. Which means if you're a woman, understanding heart disease isn't just important, it's essentially medical self-defense. So today, we're not just going to talk about heart disease, we're going to talk about how to outsmart it. By the end of the episode, you'll understand why genes are not your destiny, why cholesterol numbers don't tell the whole story, why inflammation is the real fire starter, and most importantly, how to build a healthcare team that takes your concerns seriously and helps you protect your heart. Welcome to the Medical Disruptor, a place where well-versed women can ask the hard questions and get evidence-based answers you won't find anywhere else. Our community is always informed, empowered, and science-backed. I'm Dr. E, the NP with a PhD, and I help smart, well-versed women go from medically gaslit to medically empowered. Now, guest episodes on Tuesdays are when I sit down with clinicians who expand past their training. And solo episodes like this one is where I dig into one issue in depth, and you can find all my citations in the description below because, as I said, we are always science-backed. Now, in addition to understanding your heart disease, I'll also show you how to build a team to help you with your health because you need more than one person on your team. And if you stay to the end, I'll walk you through the habits that lower heart disease risk, simple steps that you can start today. And yet, fewer than 3% of Americans do them all. 3%. This is a massive opportunity to move the needle starting right now, today. Let's first start about what it means when we say heart disease runs in the family. When we say heart disease is genetic, we're actually talking about three very different scenarios. The first is that there's a true genetic disorder. That's really less than 5% of cases. These are rare conditions where there's one gene that causes a disease no matter what you do. For example, familial hypercholesterolemia, right? When there is a family gene that raises cholesterol. Now, if you have this, you might need medication because your body is physically programmed to overproduce cholesterol. But that's actually the exception and not the rule. So that's when we have a true genetic disorder. But for many of us, there's a genetic risk, not a genetic fate. This is most people. That's when these genes don't cause heart disease. They simply make you more sensitive to things like inflammation, poor diet, stress, high blood sugar, which means that people without that genetic risk, they could eat more of the bad stuff and fare well. But for people who have this risk, they're more sensitive to it. Think of it like having, dry wood and dry grass in your yard. It doesn't mean that it will be a fire, but if a spark hits, it will burn faster than the yard next door that doesn't have it. The spark is the lifestyle, which is why two people with the same genes can have completely different outcomes because their environments are different. I'll show you an example in a moment. And then the third bunch is people who have no genetic push at all, but lifestyle pulls them in. They don't have any genes that kind of make them high risk. But even if your genes are clean, if you insist on the modern life full of processed foods and chronic stress and poor sleep, you can create heart disease from scratch. Congratulations, great job. Just kidding. So the takeaway is this: genes can set the conditions, but they do not decide the outcome. Your daily environment, food, sleep, stress, inflammation, that's what determines whether the disease process starts, speeds up, or stays silent. Family history tells you where to focus, but it doesn't tell you what your future has to be. And that's why your provider matters, not to label you genetic or non-genetic, but to help you understand what kind of risk you have and what you can do about it. So let me give you just a real life example so you could see what I mean. Two sisters, same parents, same genes, same family history of heart disease. Sister A lives under constant stress, skips sleeping, grabs fast food between meetings, hasn't exercised in years. By 52, she's on 2 blood pressure meds and ends up in the ER with chest pain. Sister B, with the same genetic risk, but she works with a provider who tracks her inflammation, she optimizes her cholesterol, she manages stress, she prioritizes sleep and movement. At 52, her arteries are clean, her inflammatory markers are low, and she has no sign of heart disease. Same genes, two completely different outcomes. Because genetics can tell you how careful you need to be, but the environment determines what actually happens in your body. Which is why knowing your risk is not enough. You need a plan and a team. So let's talk about the first member of your team. We all need to have a primary care provider, a PCP. It could be an MD, an NP, or PA, but a PCP. This is the most important member of your team, no matter what you're dealing with. They're your starting point. They're the hub that coordinates the specialist. So you want someone who understands you and understands what you like and understands where standard testing might fall short. And even if they're not willing to be the one to kind of think outside the box, they should be willing to work with you to fill the gaps. And this is especially true with cholesterol. Let's talk about cholesterol for a moment. We're going to take a moment to really understand it. It deserves its own episode, but we're here right now, so let's do the best we can. Most panels give you the most ridiculous snapshot of what's actually happening with your cholesterol. It gives you HDL, LDL, and triglycerides. And you'll hear something like this. HDL is the good cholesterol. LDL is the bad cholesterol. Triglycerides are the blood fat. And this is a total oversimplification. But that's probably what you'll get. And they'll say if the good looks high and the bad looks low, you're good. You're in the wrong situation. You're fine. And if the bad looks high, then you should just watch what you eat, right? This is what you hear all the time. But I'm going to say this, not only is this an oversimplification, it's wrong. It's actually wrong because cholesterol is not good or bad. Cholesterol is just cholesterol. It just is. It's all the same cargo. Hear me out. Well, I'm going to walk you through it. Hang tight if you're like, what are you talking about? Because if all your life you've heard good cholesterol and bad cholesterol, hear me out till the end here because I'm going to paint a picture and you will finally understand what this whole cholesterol thing is about. Cholesterol is cholesterol, okay? It's just like saying there's, I don't know, good water and bad water. Water is water. Cholesterol is cholesterol. It's not good or bad. What makes the difference is the vehicle, the truck that's carrying the cholesterol and the direction that the truck is going to. So HDL is really a truck that picks up the cholesterol from your arteries, your tissues, and your bloodstream and delivers it back to the liver to be recycled or removed. So the direction of the HDL truck is picking up the stuff in your arteries and tissues and bringing it to the liver to be recycled. This is why HDL is considered to be protective. We'll come back to that. LDL is a truck that carries that same cholesterol, but it takes it out into your body. It delivers it to the cells that need it, which is good. But if there's too many LDL trucks on the road, they now can crash into the artery walls and start damaging the walls and creating plaque. So it's not the cholesterol that's the problem, it's the trucks, okay? There's no such thing as a good or bad cholesterol. There's only good or bad traffic. So HDL are the trucks that help move the cargo in the right direction. And by the way, you don't just want more HDL. We don't want to just raise the number. We want good, efficient trucks that are going to actually pick up the cargo and take it where it needs to go. This is why, side note, like just artificially raising HDL, which can be done with niacin, doesn't actually lower heart disease. You're going to see the whole picture in a moment. It's a helpful indicator, but it's not a magic shield. And now you understand why, because we're really just talking about trucks on the road. Now let's focus on the LDL truck. Again, the standard test will tell you how much cargo is around, how much of the cholesterol is around, but not how many trucks. Another way of saying trucks is particles. It doesn't tell you how many LDL particles are around. And this is important because you can have, I'm just making something up right now, 5 trucks with 1 gallon of cholesterol each. I'm totally making this up, right? Or you can have 1 truck with 5 gallons of cholesterol on it. So having 5 of these trucks is just a little bit too many trucks. So you can have the same amount of cholesterol divided up into a lot of trucks, or you can have it all in 1 truck. And having too many trucks in the arteries on the road is the problem, not the amount of the cholesterol. It's the amount of trucks. Because when the trucks are driving around the artery, they bump into the walls and they cause damage. Now, there's actually a test called LDL-P, P for particles, or maybe we should call it T for trucks. The LDL-P actually tells you how many of these particles these trucks are around, which is a much better understanding than how much cholesterol is around. Now, so far I've talked about the amount of trucks, how many trucks are around, but we also need to talk about the size of these trucks, these particles, because the small cars, the small particles get stuck. They're sticky and they get stuck in the crevices of the artery. So if they bump into the artery, they might get stuck in there. And that's what we call plaque. Now, the larger trucks, this is where the metaphor fails, the larger trucks are fluffier and less sticky. So if they hit the walls of the artery, they kind of bounce off the walls. So it's about how much traffic, but also how sticky and small our cars are, okay? So this is why it matters. 2 people can have the same exact amount of LDL cholesterol in their body, same amount. I don't know, 100, same amount. but they might have completely different levels of danger. Person A will have a few large LDL particles, LDL trucks that are slower to stick the artery walls. And person B will have a lot of small, dense, sticky LDL particles, LDL trucks, that will stick to the artery lining. And they will get oxidized, which is a fancy word for rusted, and they will get inflamed, and they will get eaten up by immune cells and turned into something called foam cells, which stack up like sludge inside your arteries. And over time, that sludge becomes plaque. And plaque is what leads to heart attack and stroke. Same amount of cholesterol for person A and person B. Person A is traveling with fluffy big trucks, and person B has a whole bunch of these tiny little cars, and they are causing a mess. This is why you're getting to understand that the amount of cholesterol is not nearly as important as what is carrying it and how many of those are carrying it. So it's not just about how much cholesterol is being carried, it's how many carriers and the size that they are. Hopefully you're getting a brand new understanding of what cholesterol means. And a great PCP will be able to steer that conversation. They'll be able to order advanced tests that look at particles, numbers, and size. They won't just manage the numbers, HDL, LDL, but they will manage the risk, because it's really all about how risky is this cholesterol. Quick little break. If this episode is hitting home, you need this. I made a free guide called the 5 red flag phrases that signal medical gaslighting. Because if you know what to listen for, you'll know when to push back. Politely, of course. Check out the link in the description. Now let's keep going. Now here's what you can ask for on your next test. If you can only ask for one test, you're going to ask for a test called ApoB, apolipoprotein B. I want you to think of apolipoprotein B as the flags on the LDL trucks. So if we can count how many flags, if every truck has a flag on it, and we could just easily count the flags, it's a fast and easy way to count the number of LDL particles, those trucks. And if I can count the flags, I know how many trucks there are. And if I know how many trucks there are, I know how risky, right? This is the strongest single predictor of a heart attack risk. If you only ask for one test, make it this one. It's also relatively simple, and it's usually covered by insurance. So you just walk in and say, can you please add ApoB test to measure my LDL particle number? Because I've read that it's a stronger predictor of cardiovascular risk than LDL-C alone. That's it. Copy paste that sentence. It's a big sentence, but it shows your provider that you know what you're talking about. Now, there are more tests. There are plenty more tests you can ask for, but if we had to choose one, that would be it. If they are open to it, or sometimes we can ask the cardiologist, which I'll talk to you about in a moment, you can ask for another test, which is the LDL particle number and size. So if ApoB is the flag, which kind of gives us the number, there's another test that we can give us the number and the size. It's called an NMR lipo profile if you're using LabCorp. It's called cardiac IQ if you're using Quest. Now we'll give you the number and the pattern, large and buoyant versus small and dense. Another really important test to ask for, and this test you only have to ask for once because it's a genetic test, is called LP little a, lipoprotein little a. This is a genetic risk marker that most panels miss. It's definitely not on your basic cholesterol. Absolutely not. The good news is you only need it one time. It's genetic. So either you have the gene or you don't have the gene. The bad news is if you do have this gene, you will likely need medication. You will likely need medication. It's a genetic form of LDL truck cholesterol, and it is not movable or modifiable with lifestyle. So imagine a regular LDL truck, but now if you have this gene, it means that the truck is extra sticky, right? It has this extra sticky protein called apolipoprotein A attached to it. And this extra stickiness makes it more likely to stick to the artery wall, trigger inflammation, and form clots. So it's basically an LDL particle on steroids. It's genetically programmed to be more dangerous. And as I said, you won't be able to lower that through lifestyle. You'll probably need a statin to help reduce the risk. Only 1 in 5 people have this, but the problem is that most are never tested for it. Now, if you don't have it, you can double down on lifestyle. But if you do have it, you're still going to do lifestyle. Lifestyle is going to be even more important because we don't need to add to the risk. But you may be one of those people who considers lifestyle and medication because it's a major cause of early heart attacks, strokes, and valve disease, especially in women with normal cholesterol. This is the one where you can have completely normal cholesterol. You can be exercising all day long, but you're walking around with this genetic risk and you don't even know about it. And I just want to take a moment here, right? That this is what we're about. We are not anti-med. We are anti-only med, right? There are going to be times when we need both. And this is one of those moments where you would consider using both. This cholesterol conversation can go on for quite some time. As I said, it could be its own episode, but the bottom line is this: don't settle for the good versus bad headline, like good cholesterol versus bad cholesterol. You need more. Ask for particles, ApoB. Ask for more information on your cholesterol panel. And if you're waved off with a "you're fine, what do you want, why are you listening to everything on the internet," that's fine. That's called gaslighting. We're not going to change them. We can still use that PCP for other things. And then it's time to expand your team. Remember, you're going to need more than one person on your team. If your PCP doesn't order this for you, that's okay. You still need them for other things. There's plenty of things that PCP is going to help you with. And if they don't want to help you with this, that's all right. You're going to expand your team. Now, the next person you want to consider adding to your team is a preventive cardiologist, and if possible, one with lipid training, and it will say it. If your PCP doesn't want to order the test, or if the numbers are high and you want to work on them, this is your next stop. In plain English, a preventive cardiologist focuses on stopping events before they happen. Instead of waiting for the stent or the surgery moment, they measure your risk, your particles, your inflammation, your plaque imaging if needed. We'll talk about that in a second. And then they build a plan to help stabilize or shrink the risk with targeted lifestyle and, if needed, medication. So you can ask if they have training in lipidology and if they're just, if this is their level of expertise. And this expertise really, really matters. And I tell my patients this all the time when I'm not really sure exactly what to do with their cholesterol numbers. I have a great preventive cardiologist that I send to here locally. And I always say, this cardiologist will help us really figure out your risk. Will help us. It's not just about the numbers. And then once he figures out the risk, then we can safely determine what the next step is, right? It's not just about the numbers. So you need someone who understands that. Two people can have the same cholesterol number and totally different risk, just depending on their particles, how many particles, the size of the particles, and their inflammation levels. And a good preventive cardiologist can measure that. Particles, the trucks, create the plaque. Inflammation makes that plaque dangerous. So it's not enough just to have that basic lipid panel to know what's going on. You need to know how many trucks and if any of those trucks are on fire. And you might be thinking, oh my God, there's already so many tests we talked about in the PCP. There are even more tests. There are tests called CRP, which helps us figure out if there's inflammation, which is very helpful. And then if things are borderline, there's images that can be done. There's a calcium score, which is a quick CT scan that can detect if there's plaque buildup. There's a CTA, which actually checks if there's blockages or symptoms. So there's more blood tests that can be done. There's images that can be done. So much more than that basic cholesterol profile that's done in the PCP's office that could really help us determine, are you at risk of having a heart attack and a stroke? The next person on your team that you might need, depending on your situation, you might need an endocrinologist, or if you're dealing with obesity, an obesity medicine specialist. Because it's not just about cholesterol, right? It's also about inflammation. We have to reduce inflammation because inflammation is what makes the cholesterol and just makes it even worse. And if you're dealing with insulin resistance, we might need additional help. If cholesterol is the fuel, diabetes and prediabetes and insulin resistance is the fire. And people with prediabetes or diabetes are far more likely to have a heart attack, even if their LDL looks normal, because that inflammation is such a driver for heart disease. Here's what happens in a typical exam room, right? You're given a statin, you're given some metformin, your labs improve, the numbers go down, everyone celebrates, but no one's talking about the fact that the inflammation is still smoldering underneath. That's what happens when we just chase the numbers, but we're not looking at what's happening. If the inflammation is still there, we could still have a heart attack or a stroke, even with normal cholesterol numbers. So while it's really wonderful that we're also managing that, I'm not saying not to manage it, but we also have to reduce the inflammation, which is why we need someone to help us with lifestyle and metabolism, not just the labs. So this is when you might need an endocrinologist if you're dealing with obesity, an obesity medicine specialist. In plain English, they help us fix the insulin resistance before the diabetes takes hold. And certainly if you're already diabetic, then we need them on our team as well. By the way, in addition to your labs, one more crucial target is something called visceral fat, which is the fat, deep belly fat that's around the organs. This fat that is around our organs, like if you have fatty liver, you can assume it's also around your other organs. This fat is much more dangerous than, let's say, the fat on your legs because it's metabolically active. It releases inflammation all the time, and it basically takes the cholesterol damage and doubles it. It accelerates the arterial damage. This is why it's not just enough to get on the scale and lose some pounds. What we need is to lose some inches around the waist because we want to reduce the fat that is surrounding our organs. Of course, I want your A1C better, and of course, I want your cholesterol to improve, no question about it. But if we're just saying your A1C is better, see you next year, while your triglycerides are high, your cravings are high, your energy is low, and your waist is too big, that's not enough. We need to have someone planning around our inflammation. It cannot just be about the numbers. We have to really reverse that insulin resistance and reduce that inflammation. With that in mind, you might need additional members. You might need a dietitian, someone who helps you figure out how to cut down the refined carbs and add fiber and healthy fats. You might need a sleep specialist. If you're walking around with sleep apnea or insomnia, that's going to increase your inflammation. Inflammation is a really big deal. You might need someone who's a mental health or behavioral specialist to help you with the stress, because stress is inflammatory. And you're going to need a dentist to clean your teeth, clean your gums, because gum disease can fuel inflammation as well. One more to add to your team, which might be surprising, is a GI specialist. It's surprising because we're talking about the heart, right? But you should know by now that it's all connected, right? You got your primary care to anchor you. You have a prevention-minded cardiologist cooling the inflammation in the fire. Maybe you have an endocrinologist as well, but you need to add the gut-heart connection as well, because your gut can also turn that inflammation up or down. And you know this by now. Your gut bacteria might not seem connected to your heart, but they are. Back in 2013, a Nature Medicine study showed that people with diabetes and cardiovascular disease often had less microbiome diversity. That means that the microbiome in their bellies was not diverse enough. Generally speaking, they had lower butyrate, which is a really strong anti-inflammatory short-chain fatty acid that lives in our belly. And they had lower Akkermansia, which is a specific species that's linked to the health of the belly. This combination of this lower diversity has weakened the gut barrier. When that gut barrier is broken, when the gut lining leaks, what we call leaky gut, more unwanted stuff slips into the bloodstream, which raises inflammation, which worsens insulin resistance, which nudges arteries towards plaque. So it's all connected. So yes, bring the A1C down. Yes, bring the cholesterol. But we also, our first line of defense is also our belly. And we have to make sure that that line of defense is really strong and doesn't let unwanted things in. Ideally, you'll get a GI who is also literate in functional medicine. But even if not, we really need to rule out some basic GI issues. We have to make sure there's no inflammatory bowel disease, that there's no dysbiosis, that there's no SIBO, there's no ulcers, that there's no H. pylori. So even if your GI is not a functional medicine person, there is still so much basic testing that you need just to make sure that your belly is okay. And if you're lucky enough to have an integrative GI, then not only will they do the testing, but then they can also rebuild that ecosystem. But if not, you can work with your regular GI and then find a functional nutritionist, right? It doesn't all have to come from one person. We can have many people on our team. Use everyone for their strengths. Now, while I say that to build your team, protecting your heart isn't just about collecting specialists. It's about orchestrating the right people. From a functional medicine perspective, it's all connected. Every system talks to the other system. So each specialist has a role to play in prevention, and together they can make the plan stronger. Your primary care is your anchor and your coordinator. They should excel at the basics. They don't have to know everything, and they have to be willing to order things maybe a little bit beyond what the normal labs are. Then you need your preventive cardiologist, someone who knows some lipids, someone who understands inflammation and is willing to do more blood tests and imaging if necessary. If we need the endocrinologist or obesity medicine specialist, get them on our team as well. A GI clinician is great. A nutritionist that is great with functional medicine and understands the need to turn down inflammation would also be a great addition. And if necessary, a sleep specialist if you have sleep apnea or insomnia, a behavioral health specialist to help you with your stress, and a dentist, because it's all connected. Now, you don't need all of them at once. Don't panic. Don't go out and just, hire everyone. Start with your primary care. Go slow, and then add the next player as needed. If your primary care is willing to do some testing and your risk factor is low, you're done. You don't have to keep going. But if you have an intense family history and you find out some of your genetic markers and your inflammation is really stubborn, then you might need to keep going. The point isn't to have a big, huge contact list. It's about smart collaboration that you drive. You drive this collaboration. Don't expect anyone else to drive it for you. When you hit the limit of one provider, go ahead and add another one and just use them for what they need. You do this everywhere in life, right? If you're putting a party together, you have a DJ for the music, and then you have a baker for the cake, and you don't expect the DJ to make the cake, right? You have several people and together you put an amazing party together. It's the same thing here. You're not going to have one medical provider that's going to do all of this for you, but you are going to be the person who drives it and makes sure that collaboration happens. Before you start assembling your team and going crazy with all that, I want you to do a quick reality check, because there are some habits that you could do immediately that cut heart risk more than anything else. And as I said earlier, fewer than 3% of Americans do all of these together. So get these down first before you go out to get your contact list. First, if you're smoking, you have to stop smoking. None of this is going to help you if you're still smoking. And by the way, smoking means smoking. It's not just cigarettes, it's vaping. It's smoking anything. If you're smoking anything, you're putting anything and inhaling it into your mouth, except for maybe your albuterol, that doesn't count. But you know what I mean, because some of you out there think that if you're vaping, it doesn't count. It counts. You have to quit. That absolutely is first. Number two, you have to move. Okay, if you're not moving, I mean, we're not going to get so far with all this. At minimum, 150 minutes per week. That's 30 minutes for 5 days in a row. And walking counts. You don't have to get an outfit. You don't have to get a gym membership. You don't even have to get new sneakers. You could put the old ones on. Just need to walk around the block. 30 minutes, 5 days a week. That's the minimum that we need. That's going to help lower your triglycerides. It's going to improve your insulin sensitivity. It will reduce inflammation. And it does so much for your brain, but that's not this episode. But just walk. Just walk. Just walk. Please just walk. Next on the list, eat a whole foods diet. If you are eating junk food, we're not in the right direction here, okay? Look at your plate. It has to have protein in it. I prefer animal protein, but if you're against that, protein. I need some protein in there, and then I need some colors in there, and then I need some fiber in there. That's it. Protein, some colors, and by colors, I don't mean M&Ms. I don't mean Skittles. I mean like vegetables and some fiber. That's what we need. Cut out the refined carbs, cut out the added sugars, cut out the processed foods, get rid of the soda, drink some water, add some berries for dessert instead of a cake, and olive oil instead of seed oil dressings. And then number 4 on this list is maintain a healthy body composition. I'm not talking about weight on the scale, because we know that people come in different shapes and sizes. What I'm talking about is visceral fat, belly fat, the deep belly fat. That is the problem. It's inflammatory. So we want gradual waist reduction. That would be a really good measurement if you could bring that down. And of course, we want better sleep and lower stress. Now, these sound so basic, and they are. They're so basic. They're 4 of the most basic things. Don't smoke, move, eat a whole foods diet, and reduce your visceral fat. They are so basic. But if you're doing all 4, you're already halfway there. Okay, from there, you can dig deeper with the primary care and the inflammation and all the labs. But if you're not even doing that, you have to do that first. Okay, now those are the basics. Here's some additional heart healthy tips. Sleep. 7 to 9 hours. We need to sleep. We need to sleep for our heart. We need to sleep for our brain. We just need to sleep. Stress. We must reduce stress. That does not mean your life is not going to be stressful. Everyone's life is stressful. It means you have to learn how to manage the stress. And we need connection. Don't cancel the night out. Don't cancel the dinner with friends. Don't cancel going to your friend's house. Go and connect. It's really important. I love the idea of intermittent fasting. It really helps reduce inflammation. So if it's appropriate for you, I love that. And if you're feeling like you need some supplements, omega-3s are great to reduce inflammation, and CoQ10 is great for the heart as well. Okay, that was a lot of information. So let's put it all together. Here's what you need to know about heart disease. First, genes are not your destiny. Genes can load the gun, but your lifestyle is what pulls the trigger. So work on your lifestyle. Second, get the basics in place. Don't smoke, move 150 minutes a week, eat whole foods, and keep the belly fat in check. Do those 4 things and you're already ahead of 97% of Americans. That's insane. Do 4 things and you're ahead of 97% of Americans. Third, know that the cholesterol numbers that you're getting at your PCP is not the whole story. Ask for labs beyond those headlines. ApoB, LP(a), and if needed, have your cardiologist get some imaging like a calcium score or a CTA if needed. Fourth, understand that inflammation is the accelerant. It makes everything worse, and that's fueled by blood sugar, visceral fat, not sleeping, and not moving. Cool that fire and your risk falls. Fifth, if you've been told you're fine without a deeper testing or a plan, that's not reassurance, that's medical gaslighting, and you deserve curiosity and not dismissal. And finally, build a team that helps you connect the dots. Primary care is your anchor, preventive cardiology to help you with the nuances of cholesterol, endocrine or obesity medicine if you need it, a great GI, maybe a functional medicine nutritionist if you need that as well. In summary, nail the basics, get them down, demand better data, reduce your inflammation, and refuse you're fine when you're not. Your heart doesn't need perfection, but it does need partnership, a plan, and some progress on that plan. So now start with those basics, build that team, and take your power back. This brings us to the end of another episode of the Medical Disruptor. And this is what disruption looks like, not blaming, but exposing the limits of training and pushing the conversation forward. You're part of a community that doesn't exist anywhere else, a safe space for people who want real scientific information, but also want to ask questions without being made to feel crazy. Our community is informed, empowered, and science-backed. Ready to go deeper? drefratlamandre.com has my book, PDFs, a newsletter, and a link for consults. Until then, keep asking questions, keep asking for more, and keep disrupting.